for joining us today. My name is Anvisha, and today's session will be on ethical concerns in use of AI in healthcare. So this session is part of the AI and risk mitigation series at Anthill Insight. As part of this series, we're hosting meetups and talks on health tech, fintech, agri-tech, education, etc. And the aim of this project is to build a community that will engage in issues of AI security, privacy, etc., and also best practices to mitigate them. We will also aim to develop a knowledge repository in the form of practical guidelines and a self-regulated charter for ethical AI on the basis of the discussions and the session. So if anyone watching this session would like to contribute, you can also the chat box or even on the comment section. Primarily these topics should involve a brief outline of the use cases and particular AI implementation in one of the domains mentioned. So, as I mentioned, this project is part of Anthill Insight. Anthill Insight is a community where topics in AI and deep learning tools, such as AI and deep learning, such as tools and technologies, methodologies, and strategies for incorporating these emerging tech into various applications and businesses. And also AI engineering are discussed. But moreover, Anthill Insight places a strong emphasis on exploring ethical concerns, privacy, and the issues of bias both in practice and within AI products. With that, we can get started with the session. The speaker today is Dr. Olinda Timms from the Division of Health and Humanities at St. John's Research Institute, Bangalore. Over to you, ma'am.
Thank you. Thank you, Anvesha. And thank you, Anand and Hannah as well for inviting me to this forum and inviting me to speak to this group on the ethics of AI in healthcare. I have not spoken to a group of techies, so this is a first for me, but I think it's an excellent thing that we engage and discourse across disciplines so that we have a more real experience of the world as it emerges around us. Now, the session is for 25 minutes of a talk, and I will cover some of the challenges and that we are imagining and also trying to look at as far as AI in healthcare is concerned. And I hope there will be some time for engagement with the wider group and questions at the end of the session. Now, we are all very excited, of course, about the possibilities and the promise of AI in artificial intelligence and products of machine learning and large language modules. We are very excited about the applications in healthcare that we can imagine and foresee at the present time. It is mainly in the area of diagnostics, in reading of scans and X-rays, in predictive models, in research in the form of drug discovery and vaccines, and also in public health policy data that can feed and assist with the management of populations and health at the level of population. So all these are very promising promising areas that we are looking at. And yet we are concerned about some of the challenges that emerge from deployment of AI. And we are also concerned with those areas that we do not know so much about and we cannot foresee. Maybe the impact of AI systems on our healthcare systems, the extent and the scope of AI deployment, how these systems will network and speak with each other, the adoption of AI and AI technologies within healthcare. And these are areas where we are still probing and we are still inquiring into. And it is this larger area also that is the cause of some apprehension and concern when we think about integrating AI systems into healthcare. At the center of all of this is also a question about whether algorithms that are created and artificial intelligence that is going to be integrated into our healthcare systems will also be in line with the values and ethical principles at the heart of medical care. So why is this important, and what are these values and ethical principles that we are concerned about, in particular in the area of medical care and healthcare? So from the earliest times, medical care has been a very human endeavor. It is a human enterprise at the service of suffering humanity and motivated by compassion and conducted in a space that is respectful of the human body, respectful of persons, and using expertise of the time, using the best expertise of that time. And even today, if you look at the World Medical Association articulation of values in medical ethics, they speak of compassion, competence, and respect for human beings, respect for autonomy of patients. The other thing is an understanding of the ethical principles in medical ethics. And for this, when we to understand this better, we examine the doctor-patient relationship, and we see that this is inherently at the heart of medical care, and inherently it is a very unequal relationship. On one hand, we have the doctor who is informed, who is knowledgeable, who is skilled, and has expertise. And on the other hand, we have a patient who is sick, vulnerable, and does not have information about what could be the source of his suffering. And it is to bridge this gap that we require a lot of trust within this relationship. So trust becomes the cornerstone, the essential element, the dimension which is critical in the area of medical care, healthcare systems. And we are constantly looking at ways in which we can foster patients' trust in doctors and in trustworthiness. We're looking at the trustworthiness of medical systems, hospitals, and medical governance and regulations. So when there is this need for trust, it is important that then the patient can trust the doctor to care for him, to be ethical, to put the patient's needs before any other consideration. And from the doctor's side, it is important that the doctor conducts himself to the highest ethical standards, ensuring that the patient is his primary concern and the welfare of the patient is his primary concern. And towards that end, he conducts himself in a principled fashion. What are these principles that will guide him? There has been a description of many principles, but some of them are beneficence, that is to do good, to give the treatment that the patient needs, and only that treatment alone, and only if that treatment has been shown to do good in that particular situation. Non-maleficence is to do no harm. Again, this principle means that the doctor should be careful about how he administers his treatment. He has to know about the risks of every treatment, every medication, and articulate these risks. In case the risk is too much for the patient, he should not use that treatment for the patient. So this is something, again, another principle. Another one is respect for human autonomy, respect for human beings and their choices. So respecting the patient, even in their vulnerability, ensuring that the patient has information about the treatments, about his illness, about choices, about the choice to refuse, and assisting him to get the treatment he deserves. Allowing the patient to have enough information to consent, whether it is for treatments or for surgeries, and ensuring that the patient has the opportunity to consent based on what he understands and based on his own beliefs and perceptions about himself and his health. Respect also implies a confidentiality, to respect the patient's information in his illness and his vulnerability, and protect it from others where it is not required to be shared. So confidentiality, again, is a cornerstone of medical care, and is extremely important to promote trust in the medical profession and in medical systems. And the fourth, which I would mention here, is the principle of justice and human rights, in which doctors are expected to ensure that patients are treated without discrimination, respecting them as individuals. And also there is a fair allocation of health resources, and every person gets what is due to them. Now, these principles actually are embedded and enshrined in codes of ethics from the beginning of time, right from the Hippocratic Oath and coming down to our international and national codes of ethics. All of these principles emerge in one form or other. And doctors are expected to uphold these ethical standards in the interest of fostering trust in their patients. Now, unethical behavior will naturally cause discomfort, dismay, and disappointment, and could even lead to litigations. And we have seen in our times even violence against doctors and health institutions. In the same way, we apply these principles and values at the heart of healthcare. We apply them to our evaluation of medical technologies. And when we look at a new technology, whether it is in vitro fertilization or a robotic arm, we look at all of these issues alongside their usefulness of these particular tools that we use and treatments. So evaluation of treatments and diagnostics and tools also will take into consideration these values. In addition, there is medical research, which is an extension of medical care. And even in medical research, we are expected to look at a principled approach. The same principles apply, and even in medical research. So this being very central to what doctors and patients have been subject to over these years. With AI too, we will have to test it against this kind of analysis and try to understand whether with AI systems coming in, will it stress any of these values or put any of these principles under stress? So if there is cause for apprehension, should we be cautious, and should we look at it collectively, cross disciplines, looking at how best we can mitigate risk in the use of AI, which is so patently going to be useful to us, but we really do not want it to harm the patient in any way that is not reversible. And this is the time at the start that we should think about these and create guidelines. And so I'm very glad that Anvesha brought that up in the beginning, that we can use what we discuss here to possibly think of creating guidelines and so on. So let's look now at some of the concerns that have emerged and we are still discussing and thinking about collectively as stakeholders in medical care and in healthcare. One is the interface. The doctor-patient relationship. Will it change in any way? This human relationship, which until now has been between two human beings, and now there may be interfaces which include a computer, maybe a voice, simulated robot, or even a live robot that is going to take away some of the burden of the health worker and assist the patient with the care. Now, the first question that people ask is, can the doctor be done away with? Do you think there will be a time where, we won't have doctors? And I think that that time is very far away. And I don't think that that is the immediate application of AI. So we are looking at issues we are looking at situations where robots can provide information, general health information, information about illness, information that is required before a patient consents. There can be assistance with appointments, encouragement and motivation of patients who require that, chatbots that can discuss and talk with patients who require to be spoken with. And these are some of the interfaces that we are imagining at present. And I'm sure there may be many more. But even in that, are we comfortable with this interfacing with a non-human person, non-human entity? So what will be what form will this adoption of this technology take? Will people be immediately comfortable with not having a human person around? Will they miss the eye contact, the facial expression, the body language, the concern that is shown by the doctor, and simple expressions which are very human in that way? This is something that we cannot really answer easily, but it is a concern which is topmost on the mind of patients, that they should not be relegated to machines for most of their interactions, and they would like to talk and express their beliefs, their fears, their community's concerns or their family concerns, their perceptions, their anxieties, and will a non-human interface be able to handle that? So that is one of the questions that keep coming to us all this time, over time. And I think only with experience and a slow, a slow inclusion of these AI machines or AI interfaces will we be able to really get a sense of that. The other concern is with data. Even today, data is the use of data, the handling of data, protection of data, whether in healthcare or in research, is a big concern. And now with the data that is being used, which will be needed for AI systems to be most effective and be most beneficial, we envisage a time where patients will need to give up a lot of data to these systems. Now, in this case, what happens with things like consent? Does the patient will the patient consent be needed, and what form does that take? When is it taken? Will the patient know when the what the data is being used for, and when it is transferred to different networks? Is permission required for transfer and use of such data? Will this data when used by AI still be subject to Personal Data Protection Act and the IT Act, which is trying to ensure that through regulations, patients' data is safe and used well and in the right manner. So can patients, for example, refuse to give their data? And if they refuse to give their data, will they be then singled out for and not provided care? That is a question that also comes up. Will it be just an opt-in, assumed opt-in setup, or is it possible to opt out of a setup of giving providing your data? Another issue is on access and inequality. Now, this is something we see all around us all the time. We see this, there are sections of society that are chronically left out of healthcare with the lack of access to care or lack of access to quality care, whether it is due to their affordability or distance or just the lack of recognition of these groups. And this is one area that we should be concerned about when AI systems get deployed, because we are concerned that this inequality should be reduced and the gap should not actually be widened just because deployment of AI will require technology and tech platforms. And many of our citizens and much of our population may not have access to those platforms. And will then that be an issue? The other thing is who is creating this AI, these AI algorithms, and the programs that are going to benefit us, and what are their priorities? What are they looking at? What are their perceptions about health? What are their value systems? Who is creating the algorithms, and how much do we know about that? So when we think about access and inequality, we also are concerned about the fact that there is very little basic infrastructure in many parts of this country, even electricity to run anything, a system or so, and then maybe even tech infrastructure, computer, is there internet connectivity? How does this system then serve people in remote areas, marginalized people, and those who without this basic infrastructure that has become a part of the basic needs for human life? Another issue is bias and inclusion. So these systems that are being created for use in healthcare are trained on data that is fed into them, and then an algorithm is developed. It is the way I have understood it. And then what is the kind of data and the quality of data that is fed into these systems? For the first question I would like to ask is if that data was used with consent, and then if that data was in any way non-uniform or incomplete or biased in itself to begin with, and then we get an output which is again going to be biased. So we need to be able to understand on what data these machines or these tools, AI tools, is being developed. This is an important aspect of what we have to be concerned about. There is even a term that is used for it. It's called algorithmics, to understand how these algorithms are developed and what kind of output then will a biased algorithm result in. And will people be left out of it? Will it only serve a section of the community? And it could be dangerous in some respects if such an algorithm is used for diagnostics, uh, for predicting outbreaks and health issues in the population. It could really lead to a lot of harm. So doctors and health managers, hospitals, and the health systems should be really concerned about um, the quality of data and how the algorithm is created and what are the limitations of it. So this leads me to another issue of transparency and reliability. Besides the use and benefit of these systems, there should be an understanding about the limitations, the shortcomings, the risks, the cost, the manufacturer, the designer's perceptions and values. And doctors need to be able to talk about these machines, these AI machines. They need to be able to understand it, evaluate it, describe it to their patients, and ask for consent to use it on the patients. So the entire understanding of it, not just the benefits and how to use it, but it should be more than that. It should be right across from design to manufacturer to its shortcomings, and so that the patient also understands that these are issues with using AI and can decide whether to opt in and opt out. There should be an also clarity if there is a conflict of interest in with whether it is with the designer or the manufacturer or the doctor who's using it or the hospital that is using it. So there has to be a reliability of these systems and these machines. We need to have regular checks and registration and approval of these AI machines. It has to be evaluated. These machines have to they should be checked by professionals who will certify that they are still putting out what they are expected to, and nothing has changed. It's not been hacked. It's not been reprogrammed. It's not been changed, or because today we know that machines that can learn can also learn to learn. And so whether it is internally changing in any way, spontaneously, or it is true to its original function. Responsibility is an important issue as well. Where do we place the responsibility on in the case of errors and if things go wrong? Who is responsible? Now, doctors and hospitals vicariously are accountable for their treatment and what happens with medical negligence, and they are held accountable in the courts. Now, in the case of use of AI tools, what happens then? Is the manufacturer responsible, or the person who designed it, or the person who decided to buy it and use it, or is it the doctor again going to share responsibility for errors and things that go wrong? So understanding where the responsibility will lie is extremely important, so that we are responsible for what we are using AI for. If there's a breakdown, if there's a breakdown or hack into the system, what happens at that point? This should also be very clear, and the responsibility for it should be should be understood ahead of time, upfront. So in that case, in case we have to shut down systems, what happens if there's a breakdown or hack? What if we have to shut down? Will there be a parallel system of care that can be accessed, or will there be a suspension of care for the patients? These are things which are. In conclusion, I just want to say that technology moves very quickly, and adoption is slower, and of course, ethical analysis of all of that is sometimes even lags behind that. But should we always experience every fruit on the tree of innovation? And is a question we need to ask ourselves: is every bit of technology always to be experienced, or can we analyze ahead of time what is good for human beings, what do we need. Is the need, more human need, more important than the possibilities of the machine? So we need to have a very clear-eyed view on, as far as healthcare is concerned, and as health professionals, we have to have a very clear-eyed view on what is at present at stake. We can see all around us situations of lack of access, inequality in access of care, and situations that we can solve even without AI. With a lot of political will and proper planning, we can solve many of the issues that exist today, and we have the resources to do it. Whether it is the determinants of health, whether it is ensuring that everyone has equal, has a basic infrastructure, has has access to food and good clean air, and healthcare of a basic kind. We have that within our reach, and it is our responsibility to ensure that we do this before we bring in anything more that we cannot fully quantify and fully evaluate. So if AI is then this huge juggernaut that is inevitable and it's going to be disruptive, and but we don't know the extent to which it's going to do that, some of the things that we can do possibly, and I just have a few, and maybe we can think together. One is that we should have all stakeholders in at the planning and design stage for AI machines which are going to be introduced into healthcare and medical care. This is affecting human beings and very intimately affecting our well-being and our lives. It is not to be taken lightly, as with other applications of health of AI, but in particular in health. So we have to ensure that stakeholders like doctors, patients, the public, regulators, governance, governments are in or at the shop floor, at the design shop, when they are designing how AI systems will assist doctors and assist us in healthcare, right at that stage, so that all our values, all our apprehensions, all our principles are attended to. We can bring them into the planning, and we can ensure that the risks are minimized. The other thing is that AI should be, any AI machines that are being used in healthcare should be certified. It should be registered. It should be evaluated from time to time repeatedly. Doctors should be trained in the use of them much before they deploy them and they're deployed into hospitals. And patients should have the options to opt out of care, at least in the beginning, while we are introducing and integrating AI. The other thing is the infrastructure upgrade needs to be uniform so that the benefits of AI reach everyone, and there's that inclusion, that the last person is also served. If AI is going to be introduced only for those who can afford it in urban centers, then again, we are going down the path that we have already tread before, and it is not going to be satisfactory for us. Doctors, to end this, really, doctors are crucial, and they have a crucial role to play in the adoption of AI. They have to continuously uphold professional ethics and ensure that the patient is at the center of all decision making. They need to advocate repeatedly at the level of hospitals and governance, and even at the national level, at every level, for transparency, accountability, protection of data, confidentiality, and transparency and inclusion as well. And there is a situation where there could be a conflict of interest in adoption of AI, and the doctor's approval for adoption will definitely be sought, and doctors have to be sure that they will maintain the highest levels of ethics at that point in time, and not succumb to the temptation of the next new technology and its application. And they are going to be responsible for the integration of AI into healthcare. So technology is a good servant, but it is a dangerous master. And we as human beings and as doctors have to ensure that we keep human needs and human values at the center of all our discussions around integration of AI into healthcare. Thank you.
Thank you so much, Dr. Olinda. I think that very clearly set out a framework of the sort of questions that, especially even tech developers and people who are directly building these tools should think about before they build it and not as an afterthought once these tools have been released in the market. So now we'll get into a discussion between the editors for this project, Dr. Anand and Dr. Hannah. So they will be discussing with Dr. Linda, after which we will open it up to audience question answers. So if you're watching from Zoom, you can directly unmute yourself and speak. And if you're watching from YouTube, you can drop your questions in the chat box and I will share them over here. Over to you, Anand and Hannah.
Thanks, Anvesha. Anand?
Yeah, thank you.
Yeah. Thank you, ma'am. I think it's a very, very broad topic, but you've touched on almost all of the aspects that concern medical ethics, as well as what we need to be mindful of when we adopt AI into health, while keeping all of the ethical framework in mind, where the medical ethics started from and how do we continue to uphold it. So in that aspect, I mean, these are more about case scenarios that I would want to discuss a little more so that it allows us to think through it. So when we talk about we have a lot of AI coming into the diagnostic space. So one of the case scenarios here is, yes, it is a low hanging fruit in some sense, that you can deploy AI for diagnostic purposes using a given amount of data. But when it comes to medical diagnosis, when a diagnosis is made, what happens when, after the diagnosis, there is the next step that is expected for the patient. When appropriate treatment is not available, or, there is nothing that you can do after the diagnosis is made. So in a sense, we are leaving our patients high and dry with just a diagnostic report. So I want you to discuss about the ethical side of it when we develop diagnostic tools specifically involving AI.
Thank you, Hannah. This is a really very good question, and I think we are all acutely aware of the differences that exist in our ecosystem, health ecosystem, where not everyone can afford the treatment that they need. And this is happening even now, before AI and all of that. And technology has continued to come in, and there's always been people who cannot afford to use that excellent technology that we have today. Some of them cannot afford scans, some of them cannot afford IVF, some of them cannot afford, what is it, laparoscopic surgery even. So which other in other countries is like a very basic, a part of healthcare. So we have to actually look at it more holistically, even in the designing. And therefore, I know that, yes, it's easy to churn out and fairly accurate diagnostics, or once you tell the patient what happens next. And somehow there's a similarity with what happens today, even if you go to a very good specialist and they diagnose you, and then you just cannot afford the chemotherapy or you cannot afford the care. It's going to be pretty much the same thing. And so that is where I was saying earlier in my talk that we have a duty to really see that at least every patient has access to the basics. There will always be care that we cannot afford at some level or other. Whether it is, following a diagnosis that comes from a AI tool, or whether it comes from a doctor. And these are painful realities of our situation, which we cannot forget just because AI is coming in. And so I'm very disturbed when they use AI, the talk about AI and integrating AI into our healthcare systems broadly with a lot of fanfare, and they, it's being used to, speak of a utopian kind of situation where everybody will be served if we integrate AI. The truth of the matter is people are not served today. And the concern, deep concern of in public health and community health and people who are working in remote situations and with tribals and with people who are underserved and cannot access is that despite AI, the people who are unserved will remain unserved, whether it is due to the cost or whether it is due to the inaccess. So it is a painful reality of our times, Hannah, and I think whether AI is there or not, it's not going to change things for a large percentage of our population, unfortunately. And it's disturbing that authorities are willing to give a lot of investment into bringing AI systems into healthcare. Who will it serve? Who will it fully serve? And are we already listening in and addressing issues that we can address? Even determinants of health and preventive health. Are we fully there yet? And here we layer it with an expensive AI machine and its potential. And who will see this? Who will benefit from it? It's a very good question.
Thank you, ma'am. I'll ask Anand to move ahead with the next one.
Yeah. Actually, one of the questions that comes naturally when it comes to, again, who does it help? So we are sort of in a very early stage of the tech. Quite honestly, at this point, we don't even know if it helps. When dealing with, not that it doesn't work, that's not the, I mean, I'm not a denialist or anything. I'm saying that, it's fairly early, right? So what are some sort of ways, or what are some things that guide us this early? So we've got the, medical, the core principles behind medical ethics about non-maleficence and justice and beneficence and things like that. But when specifically you're evaluating tech for an intervention of any kind, whether diagnostic or not, what are some additional concerns or what are some additional principles that could be useful at that point?
So yes, Anand, I think that we have the principles, we have the values, and we test new technologies, new treatments against them. Maybe not even consciously, but we are constantly doing that, ensuring that the patient is served, the patient is safe, and there's no discrimination, and there's access for all, and there's confidentiality. So really speaking, we do this for new technologies in some ways. But there has been actually a lagging behind of ethical evaluation of new technologies in a broader perspective. So when you look at, say, for example, let's say, a robotic arm and what it can do and improve the surgeries and so on. When you evaluate it as a whole, as a box, and you're looking at, is it useful? Is it safe? And does it do what it says it's going to do? Is it reliable? Do we understand it? Is it transparent? And how was it trained? And all the questions that we said we would ask. And we come to the conclusion that it is safe, fairly safe, and so on. And this is the cost and so on. But we are evaluating just that one technology in its application. We are not looking at how is this going to help our broader issues in healthcare in our communities, in our country. We're not looking at that. If we were answering that question, then the robotic arm probably would be a very minor part of a tertiary hospital somewhere. And it would not make much of a difference to the rest of the population who cannot afford it. So when we are looking at ethics, that is why the principle of justice is so important. That allocation, the fair allocation of whatever resources there are. Every hospital that has bought a Da Vinci robot has had that discussion, right? I mean, should this money be spent on, pre-treatment for people who just can't afford and they just need that basic care to bring them and improve their quality of life? Or should we be investing it in this high-end robotic arm that is going to train our doctors, or give us a cutting edge, or afford safer surgery for people? It is doing that. It is giving them a better experience of surgery and relief from their symptoms. So we cannot deny that. But policymakers and public health professionals will be looking at the larger picture when you're thinking about allocation of resource and fair allocation of resource. Who decides this? Who is the decision makers here? These are the important questions to ask. Did we put stakeholders in the room? Did we put everyone in the room and ask them, the public, the patient, where should we spend this money? We are stewards of this money. Where should we spend it? Who will be best served? What is the most pressing health need in our country or in our community? And then look at that first. So that is an ethical concern, this principle of justice. And it's very easy to overlook it. Very easy to say that, well, this has got definite benefits. Surely, not only that, it will earn money and sustain the system, and it will also be good for surgery. But if one wants to zoom out and look at the bigger picture and wants to take a stand on where resources are allocated, then I think there is a different answer there. So with AI, I feel the same thing will happen. When you say, what should we do? We should ask these questions and ask them loudly. We should be unafraid to say that, do we really need this? Is it going to impact the patients, as Hannah just said? Do I need this diagnostic machine that's going to give me definitely better diagnosis for our patients? Obviously, we cannot, as human brains, we cannot crunch all the data that can be put into a machine. And so a better diagnostic tool, should I spend that money on that, or ensure that our patients can be treated even after they get their diagnosis? So it is a very difficult thing to struggle with. I'm not saying there are simple answers. I'm just saying that we should hear from more people who are stakeholders. Their lives and their health is at stake. We tend to be talking to each other as doctors, and we tend to be talking to each other as scientists and tech experts. But who is the end user? Is the end user in the room? Is the end user's voice heard? And are our communities heard? And are our basic needs seen to first? Especially in India, I am not afraid to ask that question first. First, see to our basic needs. And then we talk about this, catch-all terms, which is going to solve all of humanity's problems, in its promises.
Thank you.
Ma'am, you had touched upon what happens when systems fail in terms of, when we have, would we have suspension of care? That's something that, I think we need to be so aware of, because right now, I think in terms of, again, coming from the diagnostic and the imaging perspective, we have a lot of AI that is trained to look at X-rays. So are we also going to have a generation of doctors who have not been trained in reading X-rays? And, what if they are in a situation where these systems fail, that they don't know what to do? And also in terms of suspension of care, when the patients themselves do not know do they just send in their chest x-rays to a bot to report it, or should they actually be educated enough or aware enough that it needs to be reported by a trained professional? So in terms of that, can we have a discussion? What are we heading to, or what should be our thinking behind when we train machines to take over what is routinely done by humans? Are we also introducing this huge, not really bias, but this situation that we are creating for ourselves where when systems fail, we don't know what to do?
Yeah, I understand. Yeah. Yes, this is actually quite a frightening scenario, because, as you said, the more we rely on a system that we adopt, and the more that we see that the system is reliable, we will tend to lean on it. It's just that the way that adoption of scan technology, adoption of other technologies, once we begin to see that there is a fair amount of reliability, then we begin to um, so at that point, one has to ask whether, whether we continue to train doctors the way we train them. And this is also part of the question you are asking. Will medical education train to some extent? If we don't need to keep all of the data in our minds, then can we be custodians of decision making? And we be decision makers, where we use tools to help us make decisions, and then we sign off on those decisions for the patient, and explaining to the patient that this is how the decision was arrived at. These are these machines that will take in all the data and then give us this. So do we then train doctors to understand more, retain less, understand more? The change in medical education might come in at a point later down. I'm talking about many, many years down the road, because I don't think people are so confident today to let go of their method of education right now. So maybe down the road, it will arrive at a point where we can keep the information sections away from the analysis and use of your medical education on the other side. And doctors will have to sign off on even today, people are talking about having humans in the loop all of the way, making sure that there is always a check in the design, in the execution, in the audit of machines, and constantly having it pitched against the human mind, at least in these the few decades as it starts off. There has to be a human in the loop, and education might change, but at the same time, there will have to be these safety nets that we create for ourselves. Yeah, putting away keeping away our information, our research in separate buckets, so that we are able to access them even if the machines and AI machines break down. So breakdown is something that we are not so unfamiliar with, and we shouldn't be too scared of it. Because even today we are afraid of machines breaking down, like electricity not happening. We're in the middle of something, so we are thinking on our feet. We have backup systems, and we have backups in place. So I think that will be integrated into AI machines, without which I don't think any of them will be deployed. So a backup, safety backup network, and all of that will be there. Having said that, hacking is just taking over, and the more regulations we put onto it, the more you see that the hackers are, interested to see whether they can break through all of those safety, precautions that are in place. So if there is a hacking into the system, and if there is a rogue machine that people keep talking about, or if there is a machine that then begins to malfunction, and you cannot use that machine, it has to be shut down for now. We must really have a very clear plan in place, at least in the early years of adoption of AI. And I think the human being is far from being sidelined at this point in time. It's still very central to the entire thing at this point. But yes, we need to fear for the future. And I'm very confident that the human being will create a system that will not be will not abandon patients and have patients at a point where if the system doesn't work, then you're bereft. I'm sure, I don't know what the answer, how it can be done, but because a human being is creating a machine for human beings. I cannot imagine that it will introduce this. It will not have a safety mechanism of this sort. So that's a very interesting thing to think about. Medical education. The other thing you asked about is how patients will use this directly. Once they feel that doctors are trusting information, doctors are trusting robots and so on, and chatbots, and they are available at a low cost online. Once they see that, they're just like it was with Dr. Google and so on. Patients will tend to again go to these forums, go to these bots, and it's something that it will be organic, because the first thing that you are able to receive is information. Patients have suffered from lack of information about their health, their person, and their healthcare for generations, and now they have information. And here is a person, here is a computer or a screen that can give them information about their health, now what we are concerned about is if they consume that, presuming that everything about it pertains to them and everything about it is right. Because the nuances in human beings, remember that, I always tell this to medical students, that medicine is still an inexact science. And there are huge gaps in our knowledge about disease and causation still, and also there is a lot of variability in human beings. So when machines are putting out data that is for our health, ideally it should be customized for that patient alone. You see? So if it is going to be generalized information coming out of an algorithm, we have to be greatly concerned about it. So there is always the need for a doctor who can qualify what is being told to a patient on the internet or through AI machines, because it is to be tailored to that patient's environment and background and hereditary and his diet and so many other things which are very, very specific to this person alone, including his genome. So given that every person is so unique, can there be data like this which is put out that, which can mislead them? And so again, we have to be all the time educating our patients about use of chatbots, use of wearables, the limitations of them. It's not that they're not good. It's just that people only talk about the benefits and how to use it. I feel there's very little emphasis on limitations and drawbacks of these technologies, and because the market promotes it. So we have to be the persons to caution the patient about the information they receive, the applicability to them, the treatments that they want to take based on what they hear, and whether this kind of diagnostics is actually, which the patient is self-motivated, self-led diagnostics, is actually on the right path.
Thank you, ma'am. So to continue, along these lines of, what happens, again, we're talking about, the future, in situations in which we are more comfortable, in the use of these systems for, assisting in health decision making. And one of those types of decision making is some kind of, predictive, modeling. So already we have things in the market that tell you, that can predict your risk of a certain disease or a risk of a certain, this and that and things like that. And this is kind of being embraced quite, a lot by governments. It's being embraced by insurance agencies. It's being influenced by a lot of people who have, by employers, who have certain amounts of authority over people, right? And given that both that the science of it is new, the tech of it is new, and that there is a certain amount of additional disproportionate power, what are the sort of ethical issues here about specifically about things like, so let's say that, there's some lifestyle modification that is needed for me to deal with this, this disease, right? Is there some kind of a interference there with my agency and, patient's autonomy and things like that? And, what could be the issues there?
Yeah, I think this is also a very good question, and it's a concern that we have even now in the current system, because there are always nudges, that we receive from either insurance or hospitals or doctors about how we should, prevent a health catastrophe rather than look only at curative measures. So now it so how much will governments, doctors, hospitals, our insurance companies control our lives? And this is the question I think you're asking. And how much do they control it already? I wonder, And is there that agency that will be retained after we are all, co-opted in, or we've all opted in into a massive or convoluted networked AI for health? In which case, is it possible ever for a patient, for example, to say, this is enough, I want my data back and I want out of this? Is that possible at all? Will it be possible maybe in the beginning that you can refuse to have your diagnostics done by an AI machine, but you'd rather want your doctor to do it? Maybe that could be standalone, something you could refuse. You could refuse to have your scan looked at by a machine. Though I must say, there are scan machines, retinal scan machines are already in use and licensed. So there are very good, the reasons for patients to say yes to it, of course, many good reasons. But there could be a person who says, I'm not sure, and I want the doctor to read that scan, and I don't. So they can opt out of bits of it now. But I'm talking about when all the systems start speaking to each other, and you're talking about your healthcare delivery along with your diagnosis, preventive, and your government insurance and other insurance schemes all meshed into this network. Then will there be an option to step out of it? Or is it going to be at your own risk? And then you are left to find treatments, and there'll always be. One thing I know about human beings, and history has taught us, there'll always be the parallel thing, right? There will be alternatives for care, and there'll always be alternatives and people who are not interested in being part of a tech machine and so on. So there'll always be those. But yes, they won't be served within the system. So protecting autonomy of individuals at any time, it's like we talk about in research, right? You can opt out at any time of research. We tell people that. We give them all the information. We tell them, we get their consent. We start them on the research, and we almost, it's a given that patients can, of their own accord, opt out. And we respect that. So can we do this for AI? Will it be possible? My understanding of AI isn't complete enough to know whether such a thing would be possible at all. Will we all be part of an enmeshed network where individuals will count for less than populations? Maybe we're looking at communities, populations, and treating them as such. And so you can't opt out without losing your care. It's quite a negative sort of a dystopia that people have only written about, and I hope we won't reach that point very, very early. In the early phases, I certainly see that patients will be able to opt in and out of use of AI for their tests and for their treatments and diagnosis. Certainly that will be there. Now, what pressure comes from the governments and insurance agencies is for us as doctors to actually resist that and ensure that as far as possible, patients have choice. Just as today we are resisting it with and hope and advocating that insurance covers more than it does today. The same way, we need to advocate And this constant, doctors will have to take the role of probably, activists in this area, maybe for some time, to make sure that their voices are heard. Because doctors are subsumed more or less within the system now. The way that commercialization has permeated most of healthcare, doctors are mere actors, within the system, and they don't dominate and stride across the landscape as they used to, with voices and opinions that are heard and valued. And so we need to recapture that autonomy ourselves, as doctors and health professionals. We should be autonomous, we should have a voice, we have to advocate, and we should be heard. We are not just tools in a healthcare system, though many would like to believe that we are just technicians.
Anvesha, how are we on time?
Yeah.
I think if anyone from the audience has questions now, they can unmute themselves and ask. There are no questions on YouTube as of now. So if anyone here would like to ask a question. Yeah, go ahead, Ramit.
Thanks, Anvesha, and thank you, Dr. Olinda, for such a great discussion. I'm from the Center for Internet and Society, and we're actually doing a project on AI and healthcare, and we're looking actually around the auditability of AI frameworks that exist within healthcare today. So the question that I had was, of course, we know that data is being collected, and then data is being processed, and then finally it is being used for some of these use cases that we've spoken about, whether it's diagnostics or disease surveillance systems that are, or predictions for diseases. Are there any particular checks and balances that you think should be made necessary, particularly at the point of data collection and data processing? Do you think there will be differences in the ways in which we apply certain checks and balances? That's one question. And the second question was also around, where is the data coming from? So for this development of these AI systems, one of the things we are grappling with is it public health data? Is it proprietary data that is being used to develop these systems? So if anybody could also reflect on that, whether Dr. Olinda or Dr. Hannah or Dr. Anand. Yeah.
Okay, I'll go, and then maybe Hannah can also pitch in. Yeah, this has been one of the most, contentious issues, because development of the technology and development of AI and algorithms has happened already autonomously by groups like companies and people, individuals, people that are seeking how to use this and how best it can be used for others. So I don't think there was much consultation at that point in time, about how it will be used and all of that, and which data is going to be taken. Whatever data was available, many of them are saying that whatever data was available was scraped and used, and that is a big ethical concern for us. Because if it was done in a systematic way and there are obvious benefits, what should have happened was a stakeholder consultation to begin with. And then you decide, okay, for this purpose, what is the kind of data we require? How robust is that data in itself, and how complete is that data? Then use that data. Everyone knows there's transparency about what data is being used. Then you can look at the output and see whether it is true to what you have designed the algorithm to serve up. But now it's like after the event, we are looking at the machine created, and then we want to go back and say, whose data was that? What was that about? And I think it's going to be very difficult for us to get them to admit what data was used and what it was. This is going to be a very big problem. So we can only think about going forward, which is why for the first time ever, I have seen, at least in the short span of my engagement in bioethics, I'm seeing in this space, particularly about AI and AI machines and tools, that there are guidelines out and up before even the adoption of the technology. This is the first time ever. Usually, with surrogacy and IV, all of this, it followed. The AI, the ethical discussions followed, and regulations followed to fill the gaps and so on. But for the first time, regulators, governments, WHO, there's a Rome call for ethics in AI, and there's a ICMR guidelines on AI, and all of them are speaking of the same kind of concerns, and they are also concerned that the machines are already being made. That is the big concern. So when you're talking about that data there, you're not going to get those answers very easily from these people because it has been taken without consent. It has been scraped off open access. So um, uh, I do think that it is important for us to actually reject any AI machine that is developed, no matter how good it is, if we don't have this understanding of where the data is from, what kind of quality of the data, whether the data was biased, and who decided what data will be used, what are the values of that person who decided, who is the programmer, who is the person behind it. This is not going to be a time where we look at a little tech tool. We are looking at a whole system, and it's going to be deeper than that. So we have to be very conscious, and if necessary, even reject, unless, and start again. There's no harm in it. And with the rate of the way we can do things these days, it's not that we're going to lose time. We have issues, as we discussed during the talk, that we have to sort out anyway with infrastructure and everything before we can deploy AI. So, there is a run-up time. We should not be in a hurry. This is the first time that there are these international and national level guidelines for use of AI. We must not be in a hurry to use it. What was the other part of your question, Amita? You said you asked about the kind of data used, and
yeah, one was the kind of data, and the second was like, of course, post facto now, but like what kind of auditing frameworks should exist and at which points, and should it be at the point of data collection, at the time of data kind of cleaning, handling, at the time of data processing? And you see like there should be different checks and balances across these various stages of the data lifecycle.
I think all of the above, and I think there should be always a certification and understanding of the technology, description of it, look at its reliability, test it out on a small population, the same way that we look at any other kind of technology, and put it through all of that, not miss any point of that kind of evaluation and review. And then it should be reviewed and audited from time to time, because here is a tool that is different from other tools in that it brings a kind of a machine consciousness into the loop. Other things like robotic arms, and I've talked about other technologies and scans and all that, do not have that aspect. So here is a machine that is learning and learned on material and continues to learn. And that is also, it's written into the program that it should continue to learn. So can it then start changing and evolving? We don't know the capacity of it. So all of that has to be constantly evaluated, at least in the beginning, until we get more confident of that. I don't know. I think Hannah might have some more to add on the kind of data.
In terms of data, I think I agree with ma'am. Yes, if we are not, at least once it is for healthcare, and before deployment, at any point we feel it has not been trained for the intended audience, and that they have not been represented in the models that have been trained, then it is the onus is on the person who's evaluating it just before buying it or at the point of deployment. I don't think the onus is always on the government, always on I think even the technician should be aware of what questions they should ask. Has this been trained for this particular demographic or this particular group of patients, and can I trust the output or values that it is spitting out? So most often what happens is we find that AI is trained on some amount of local data, but it is packaged to serve as a for global use. But when you are in AI, you know that there are limitations and there are caveats. So that has to be out there for public use or for public knowledge, that this has been trained on this particular group of patients. This is this kind of data that we've used, and it is applicable for male population from this to this, or it includes for all genders from this to this. Whatever we give our range of values that it will work on. If that if most of the users are aware of it and they demand that, industry will have to put it out. And if regulatory authorities are asking for it, then the companies are expected to do that. So it is also about users, it's about people who are making these decisions and policymakers to ask these questions, to make sure that everybody is aware of these things, and these guidelines are followed. So
Yeah,
I think the other thing also is about who is funding this. We don't ask this. Who is funding it and why are they interested in funding it? If it is being funded for a particular group, and all the testing is done outsourced and done somewhere else, we need to ask those questions. And if it is not for the benefit of our own patients, why should our data be used?
That's a very good point, Hannah. And I think, my nightmare is, the way that things are going today in this commercialized healthcare environment, that, hospitals and health systems will be vying to adopt technology, and especially AI machines, and then use that as a selling point. And they will override all of these concerns, because, ultimately, if it's going to be making them money, I think and that is what's happening today. It's anyway happening today. There are people understand ethics, they know about ethics, but they decide that it's not something they want to do. And patients are suffering on account of that. And the inequality is on account of that. So my nightmare is that they would do something like that. In an ideal world, the government is now poised, ready with guidelines. And what it could do is what it did so successfully with when AIDS was there, HIV/AIDS, at the whole campaign to limit HIV/AIDS. Just go on a information blitz. Inform, educate, inform, educate. People will understand. They do not have to have a science background to understand this technology. And everyone is tech savvy with their phones and so on. And tell them the limitations, warn them, put out the cautionary notes. It's not something that one has to, like, there's no fanfare associated with the introduction of AI into healthcare. It is with a lot of caution. People have to be aware. And if this awareness goes right down to the grassroots, then people will start demanding things that they need. Because they will see that these things may not apply to them, or they may not be able to afford it, they may not be able to get the treatment, as Hannah had said, and all of those things. And they will begin to ask for what is their rights and what is their due. And they will be saved from unnecessary entrapment into errors of AI systems. So we are poised at a very good point in time now, when we can do this awareness and do it at the national level, do it using all of the media that we have at our fingertips, and keep getting people ready and aware. Then they will know what questions to ask. Then they can ask the doctor. Then they can evaluate even what they're listening to online. But the onus is on the government and the authorities, health authorities, to do it now, before people start buying these AI machines and using them in the.
So I think the only thing I want to add on here is that we shouldn't be confusing AI with, in the sense that in the last few years, there is, our imaginations about artificial intelligence have been captured by what large language models and diffusion models can do. And these are data hungry, models that are trained on, ridiculously large amounts of data to do like pretty, simple tasks. And unless we decide that this is it, we're going to stop here and go, no, further. There is no reason to believe that that kind of a data hunger is going to continue. And I think it's important that we also push for growth in the industry that isn't just happening, that is saying, that's it, we've invented transformers and we can stop now. Yeah.
I think with that, we could close the session. It was a very insightful conversation, and we'll be having more of such sessions around AI and risk mitigation in health tech, education, finance, public services as well. So yeah, I've shared a feedback form. Please do fill it and suggest any topics that you would like to hear on under this project. And thank you so much, Dr. Linda and Hannah. It was a great conversation. And hopefully we'll speak again soon.
Thank
you
you,
so much, Dr. Linda.
everyone. Good night.
Thank you, ma'am. Bye, Anand. Bye, Anusha.
Bye. Good night.
Bye.
Good night.